So I'm Jim Letts. I'm a family medicine doctor at MHealth Fairview Roselawn Clinic. I've been there for 21 years. And I also work as medical director for our community advancement program for MHealth Fairview. And I'll let Kate introduce herself.
And I'm Kate Iverson. I work with community dental care. I am a dental hygienist. I've been a dental hygienist for many, many years, but I've worked with community dental care for 17 years now, I believe. And I work mostly now, I started out as a collaborative, or as a clinical hygienist there, and then ultimately was able to get involved in their community programs. And that's what I do now.
All right, so just a little bit about MHealth Fairview. We're a large integrated health system. And we have a community advancement team that works on sort of really upstream health interventions, trying to impact health early in the process. And this collaboration with Community Dental has been one of those that came out of our East Side Health and Wellbeing Collaborative that started about 10 years ago. And our community advancement team and MHealth Fairview overall are really proud that in 2025, we were awarded an award that the American Hospital Association gives out once a year to a health system in this country for their community work. So not their clinical work, but their community work. And that's the Foster McGaw Award that MHealth Fairview won in 2025, in part for the work that you're gonna be hearing about today.
And can you hear me if I just stay right here, if we don't shift? Yeah? So maybe we don't need to go back and forth. Oh, you can't hear me, okay. Never mind. I just wanted to tell you a little bit about community dental care. Their clinics opened as a nonprofit in 2005. They started out, I think at that time, with 3,500 patients, visits per year, and we have grown to 110,000 this last year. We have 5 clinic locations throughout Minnesota. The newest of which we're really excited and proud of. It's a relocation of our St. Paul clinic, the original St. Paul clinic, and that went from 16 operatories to 40. And 14 of those are dedicated to pediatric care.
All right, so I guess these are our objectives for today's presentation. I just wanted to start to tell you a little bit about Roselawn Clinic, and because that kind of tells the story of how this collaboration came about. So Roselawn Clinic's a pretty large primary care clinic. We have 14 physicians there, 1 pediatrician actually, the rest are family medicine. And we have a history at that clinic of really kind of a passion for working with underserved communities and helping those communities achieve better health. We do that not on our own, but in partnership with community partners, and a really important one of whom has been Community Dental Care. And through that work over the last 20 years, we've built some really good relationships with underserved populations, refugee communities in particular. You can see that our patient population is really diverse at Roselawn. About 68% of patients are BIPOC, and that we have our largest patient population over our Karen refugees from Burma. So for those of you that don't know, Karen people started to resettle in Minnesota about 20 years ago, and then came in larger numbers over the last 10 to 15 years, fleeing civil conflict and ethnic cleansing in Burma. And Minnesota is home to the largest population of Karen people outside of Asia. There's about 20,000 Karen people now that live in the greater St. Paul area. So they came here as refugees from refugee camps where most families had spent an average of 10 years in a refugee camp with 0 access to dental care or dental services and some access to basic medical care. And so what we were seeing at Roselawn Clinic with our patients as the numbers of Karen patients that we were seeing grew, and we saw similar things in a lot of the other populations that we serve, but as we would get together at our physician meetings and our care team meetings and things, we were realizing, that, wow, a lot of kids have severely advanced dental disease, by the time they're 4, 5, 6 years old, and have had no access to dental care, so no dental treatment whatsoever. We realized that parents were afraid to give their kids tap water based on their experience with tap water in the refugee camps, so the kids were not getting any fluoride in the water. We realized that when we would refer kids to a dentist, which we don't have a formal dental program in MHealth Fairview, so it's not a formal referral. It's more like, hey, you need to see the dentist and come back for your next well child check. Most of those families that we were concerned about weren't navigating to dental care. So we would see a kid with a mouthful of cavities, for their 2-year-old well child check, and then we would see them back for their 3-year-old well child check, and it was worse, and we'd say, hey, did you see the dentist? And there were too many barriers. The family was not able to get that kid in with the dentist. We would talk about just how we were seeing the stuff that you guys all know about, the kind of social sequelae of untreated dental disease. So kids that were having chronic oral pain, kids that were missing a lot of school and suffering the kind of social consequences of that. So we got together as a physician group and said, hey, this is kind of unacceptable. The trigger actually was, we talked about how many preoperative exams we were doing on 3-year-olds, 4-year-olds, 5-year-olds, 6-year-olds for full dental restorations under anesthesia at the hospital. And we kind of just said, this is completely 100% preventable. This is really depressing that we're literally doing, like a few a week, some weeks on these little kids, and there's gotta be a better way. So we were part of this Eastside Health and Wellbeing Collaborative that I mentioned before, and Crystal Yang, who's here, was one of the founding members of that, along with a bunch of nonprofit organizations across the East Side that were together figuring out how do we impact health upstream in the broader sense. And so Crystal and Ann and Karen were the community dental team that were part of this collaborative, and then myself and others from MHealth Fairview. So we just started having side conversations. Hey, how could we reach these kids? Community dental knew better than I did that those kids needed to be reached and were struggling to navigate to dental care. So we both had the same frustration and decided to do something about it. And so I guess in summary, from a primary care physician perspective, we were seeing these kids with chronic oral pain, kids missing a lot of school. We were seeing lots of kids going to the ER with dental infections. We were seeing thinking about, I guess I should say, just the long-term chronic disease and cardiovascular risks that go along with poor dental health. And again, how can we make an impact and get upstream and do something about this?
So really, you've said it all. I guess what I would finish up with there would be that baby teeth really, really matter. And they help kids eat, be healthy learners, and it helps them to grow a healthy adult smile as well. So let me just give you, many of you have seen these statistics before. If you're poor, you're twice as likely to have problems with dental decay and much less likely to have that decay treated. They lose tons, 51 million hours of school hours are missed due to dental issues for kids. 25 million was spent at ERs this is a Minnesota number, for dental care costs that were non-traumatic in ERs. Again, all of these are really unacceptable, and what I think hits me the most is that even those who are covered by public programs, only 3 of those may be seen for dental care. So our program makes a difference in that regard because 7 of those folks that are seeing you in your office, Dr. Lutz, and the medical teams there are not being seen for dental. So we're taking the dental care and assistance to them there. I think in terms of, we're going to move on to design and key features. I think, do you want to begin?
Yeah. So we started to think about how can we take a primary care clinic that's trusted by these populations and has been doing this work with them, for 20 years, where the kids show up and, they're there for their well child checks, and how could we take advantage of that and get them dental care. So we decided to schedule kids for their well child check and then have a dental visit in conjunction with that. One of the huge advantages of that was that a lot of the medical assistance programming or insurance will cover transportation to select medical visits, but there's no coverage of transportation to dental visits. And so we took advantage of the fact that we could get these kids across their transportation barriers and get them to our clinic and then have a dental visit at the same time as their well child visit. So that was one of the key ingredients to our success. Then we figured out, with a lot of trial and error, we figured out patient flow issues and how this would work to have a pretty comprehensive dental visit done in conjunction with a well child check and not make it too disruptive to our primary care teams, adding on this significant component without disrupting clinic flow in a really busy clinic. One example of how we flex things and make things work was, initially it was the well child check was completed, and then the patient and family was taken down the hallway to Kate's room to have the dental visit. And Kate quickly told us that wasn't working because a bunch of screaming kids after they got their vaccines, full of tears, were not going to not participate in a dental visit very well. So we flexed and changed that so that all portions of the well child check would be finished except the vaccines wouldn't be delivered. Then the child would see Kate for the collaborative dental component of the visit, and then vaccines would be given as a final step so that the crying baby could just leave. So I mentioned that we integrate the dental visits into the well child check, but we don't exclusively do that. So we also learned that we could capture a lot more kids who had not accessed dental care previously if we just were flexible. And if a kid was in for their asthma check and our physicians knew that this was a child and family that struggles to navigate care, we would say, hey, have you ever seen a dentist? And they would often say no. And then we would say, hey, could we walk you down the hallway to meet Kate and get a dental visit right now? And most of the times the families were like, of course, the advantage of being able to get the well child check and the dental visit done at the same time, the advantage for a busy mom, or a dad trying to cross all these barriers was huge. I think Kate's going to talk a little bit about follow-up and referrals.
Sure. Yeah, I just wanted to add, too, that one other nice aspect of this is that there's the fact that we work together so closely with the medical staff there. A lot of the participants that join our program join us for dental because they have so much trust and faith in the medical providers, and they don't have that same relationship with a dentist. And so it's a kind of a soft handoff to dental, and then they begin to trust us more, and they're more likely to find a dental home that way as well. In terms of referrals, one other thing I would mention is that as Dr. Lutz mentioned too, a lot of the medical providers just send us folks that come to their clinic with issues, or they notice something, and they refer them to us. So they may be older. Our target is younger children, but we see people of all ages who have issues and need assistance. The referral process, so a number of the children that we see, we can't treat. Their needs are beyond our ability to treat or beyond the scope of the services that we can provide there. So we have a very robust system for referring those children. We use community dental care if they want to see us. I can either schedule immediately while I'm there, or I can connect with staff back at the clinic who speak their language and can contact them and help them schedule. We often will see one child at the clinic, but the whole family wants to come in. So we're able to navigate that for them. We also have other resources for them. So if they want to choose their own dentist, we have resources that will help them locate somebody within the community for that as well.
All right, and then, so as far as how this has been received by patients, they love it across the board. The families have expressed gratitude repeatedly, like, this is so nice, I've wanted my child to see a dentist, but we just haven't been able to get there for whatever, transportation reasons, insurance reasons, financial reasons, just general chaos of life reasons. And so this has been really successful with patients and families, and they've really appreciated it. It's also been hugely successful with our provider group. You can read some of the comments there from some of my partners who universally love having this program and see the benefit that it has for the child's overall health and well-being. In fact, we have a sister clinic, Rice Street Clinic, that is not too far from us that serves a similar patient population. And the physicians there started hearing about this program through the grapevine, and we're like, hey, why can't we have that? And so we were able to expand to Rice Street Clinic last year, and the program there grew extremely quickly. And you'll see some numbers here in a moment about how busy this has become and how many kids we're reaching and serving.
So this slide just shows you a little list of what our current model looks like. And when I say current model, we still, I think an important word for this kind of collaboration is flexibility. Every appointment is slightly different with these families and children. But these are some of the services that we offer. We offer preventive care, the dental screening, counseling, all of these things that are mentioned. We provide silver diamine fluoride through collaborative agreement, so I can connect with Dr. Siobhan, who's here today, who is a great collaborator. I can connect with her right away so I can apply that silver diamine fluoride, help manage the disease until kids can get additional care. We follow up with those kids as well. One other thing that's not listed is we do have a Nomad, a portable camera that we can use to also triage patients, and we use that as needed to evaluate and then help kids get the care that they need beyond the scope of what we can provide during the clinic time. They have limited time, of course, in a well child check, and parents leave work to take care of these appointments, and so we try and work as efficiently and quickly as we can in that time frame as well. This gives you a little bit of information. This is just from January of this year to the end of August. And our numbers, we saw by the end of August, 484. We had 484 encounters. We have seen in that group there were infants to folks up to the age 54. We primarily focus on 6 months, like when that first tooth comes in, up to 15 years of age. And we also we're trying as much as possible to get upstream from the disease process. So we also have developed some packets that we can provide to pregnant moms, as well as those going through after that birth comes. We have kits for parents and children and information in a variety of languages that help them to care for that infant's teeth before a tooth ever comes in, and then shortly afterward. And it includes supplies, oral health supplies, and a little book and some information. Those can be actually given out. Those are given out when we're not there. So even when the dental program isn't taking place, we still have an impact on those communities and within the practice. And then we get referrals from the medical staff, as I mentioned before, when it's not related to a well child check, but they see issues that are developing for those families. Then I'm going to give you a little bit more information about the impact of the program and a little bit of data. So this, again, is that same time frame, so January to the end of August, and it kind of gives you an idea of what our patient or our participant group looks like. Over 60% of the participants had not been to the dentist in over a year or had never been to the dentist. So you can see that. As far as ethnicity and race, 98% are BIPOC, which Dr. Letts tells me is unusual. I'm kind of getting used to looking at these numbers, but that sort of demonstrates the inequity of care there. We have a little bit of information about the insurance or payer status. 93% of the children or the folks that we saw in the program were covered by or enrolled in public insurance. And then there's a small percentage, 3%, maybe a little bit more, that are uninsured. And in terms of referral status, about 30% upon screening require referral. So they have disease of some kind that it's obvious and we can see and we want to refer for that. 3% of those 30% are urgent referrals. So again, we're trying to make immediate appointments for those folks and work through our team back at Community Dental Care to help these particular patients get seen in a really timely fashion so that they can, we can treat whatever needs they have. The others are also referred, and we have a variety of ways of reaching out to them. We have a number of staff who speak the languages that are common in the groups that we work with at both Rice and Roselawn Clinic, and so they can reach out in the patient's own language and help them navigate the system a little bit. The other thing that's kind of valuable here is that 70% don't require referral, and that gives us an opportunity in those cases to get ahead of the storm and talk with parents a little bit more about nutrition. We can do nutritional counseling, oral health, oral hygiene instructions, get them supplies. Sometimes we've found that one family is using the same toothbrush. All of them are using it. So I'm able to talk with them a little bit more, get a feel for what they're dealing with and what obstacles they're facing, and help to overcome some of those. So this is a picture of one of the children seen who was, I think, 3.5 at one of our clinics. And we're hoping to avoid this level of decay. That child had 14 teeth that were pretty severely decayed. And these end up being hospital visits, obviously. So our program really, we feel, is a smart investment. It increases access to care, it improves health equity, and improves quality of life while still lowering costs. It's innovative, and it really is aligned with value-based care. So that brings us to, we have figured and estimated that for us to have a collaborative hygienist in clinic available right now costs between $65 and $75 per encounter for early intervention and education, which is a fraction of the cost of hospital care.
Yeah, so those kids that we were seeing and doing the pre-ops for, over and over again, when you think about those kids are going to children's hospitals for inpatient dental care, And when you add up the preoperative costs and the hospital fees and the anesthesia charges and the dental and the inpatient dental services, it's like $15,000 per intervention. And so, just on a common sense, like dollars and cents approach, like this type of medical dental integration should be at all clinics that serve, patients that have populations that have difficulty navigating to dental care.
Yeah. So we're going to kind of wrap things up with a little story, a success story for MDI, and it was hard to choose because there are many, many of them. But one that comes to mind in particular is when we first went to Rice Clinic this year. One of the medical doctors was seeing a child whose father brought them in because they had fallen, and he thought that the pain that the child was experiencing was related to trauma from the fall. And when the medical team took a look at it, they thought there was something more going on, and I happened to be there that day for dental. They brought me down, and I was able to do a screening for that child, and I saw severe decay and an abscess developing, and pain was associated with that. It was not trauma. And I was able to connect with Dr. Siobhan right away. She's kind of always available for me, and sent her some images, talked with her about it. That child happened to be uninsured. But through Dr. Siobhan and the work of community dental care, we were able to get that child seen the next day at a Give Kids a Smile program that was happening at our clinic. And they squeezed her in between a couple of other patients. One of our other dentists saw her and was able to treat that. And that child's out of pain because of this partnership. That wouldn't have happened nearly that easily without it. So there's lots of stories that I could tell you, but instead of giving you more and more of that, we thought we'd end here and offer it up for questions. What questions do you have? Is there anything that you'd like to know more about?
Oh, I might have missed it, but when the patient calls for their well child check, that's what they get scheduled for, or do they get scheduled for both visits? Or do they just go to the well child and then the doctor finds out they've never been to a dentist and sends them out?
Sometimes that happens so sometimes the doctor will see the child on a day that one of our team isn't there for dental, and they will actually schedule that patient on a day that they can see one of the dental team, if that's the case. But typically our schedule is set up, the schedulers up front have a list of all of the children who have well child checks that day, and they are provided that opportunity when they come in.
Gotcha.
Yeah. So it's not pre-organized in that regard.
So our front desk team has been a critical part of this. So as patients check in, I see that your child is here for a 6-year-old well child check. Has your child seen a dentist before? No, they haven't. Would your child like to see our dental team today? Yes, that would be great. So it's at all levels of our clinic. So front desk, nursing staff, physicians, that are trying to get kids in touch with this service.
Yeah.
Well, first, kudos on your program and your presentation. Absolutely fantastic. And I'm just curious, because it is clearly impactful. Has Fairview or Community Dental Care or any other group done anything to estimate how much you have saved, the cost benefit of this? Because you made kind of a comment, and I agree. I think absolutely every healthcare program should have this kind of a collaboration. So has anybody documented your financial savings and impact?
We've done some of that, but not a really kind of formal, solid kind of analysis of that. Anecdotally, at our clinic, we rarely see kids now for the pre-op, for the full dental restoration under general anesthesia at the hospital. That's anecdotally. But we've worked with community dental on, some of the collaborative ways to get grant funding to, as this has expanded over the years. And we hope to continue to expand it to other Fairview clinics that serve similar patient populations. And that's probably a key kind of ingredient that we'll need to really start to move this beyond piloting and into more and more clinics. So good point.
Dr. Nelson being on the Dental Services Advisory Committee, I mean, to me, this is broader for policy change to make the reimbursement work. Yeah. Thank you.
It's a great point.
So, such nice presentation, I feel so energized. So the state is looking at rural health right now and applying for some federal funding. And one of the key considerations is to see how we can add dental to the rural hospitals. So if we were to approach primary care providers and tell them the value of this project, what would be the key to approach to them? What should be our key message from the state? So we go beyond the funding only and go more statewide and think about system level and policy level changes?
Yeah, so I think one of the key messages would be, so initially we wanted a dental chair in our clinic with a dentist and a hygienist and a full spectrum, collaboration like that. But and some clinics have that, a lot of federally qualified health centers have that. Some clinics are lucky enough to have that, but to be honest, most clinics aren't going to have the financial resources and the sort of relationships and things to make that happen. So I think a key message is you don't need to do that. You can just have a collaboration with a community-based dental team and have amazing people like Kate who are willing to kind of be there and get to know the team and become part of the team. And that's really all you need. It's very inexpensive. And so that's, I think, a key message, that this collaborative dental hygienist model backed up, by the dentists and the team at Community Dental Care is really affordable and fairly easy to implement.
I would say, too, a really important component is to have on those two teams some key people who really, really are passionate about it, and then they can carry it further. So, I think getting the right people, getting in touch with the right people will make a big difference, too.
Thank you.
Thank you. Oh, another one?
Yeah, sorry. Do you track any of the services that you do at Community Dental Care in the medical record at Fairview?
Can you repeat that question?
Oh, sorry, yeah. The question was, do you track any of the services that are provided through our partnership during the time that I'm there in the records, the medical records? And I have access to Epic. I am able to communicate with the physicians related to a particular person. So for example, if I have a specific concern about a child, or I apply silverdimine fluoride, or there's hospital dentistry, I can message them that information, but it's up to them to put that into the format itself. We work separately, and again, that could be streamlined. In the future, I would hope that would happen. But we use Open Dental, so we have a record of the visit within our records, and then they have their separate Epic records that includes and we do the consent. They fill out a consent form that's dropped into scanned into their chart. So there is basically a record of the visit, but it doesn't go through the details unless they add it on their end. Does that make sense?